Hello and welcome to the Food Animal Medicine lecture of the NAVLE preparatory course. My name is Dr. Carlos Risco. I met some of you last week at the beginning of the course. I am delighted to be the co-coordinator of this course with Dr. Paul Gibbs. I am an associate professor in the College of Veterinary Medicine, Department of Large Animal Clinical Sciences, and my specialty is theriogenology. I also have a major teaching component in production medicine or herd health, and primarily I'm going to discuss with you or review with you diseases in beef cattle and dairy cattle. My objectives for this lecture include to review with you the physical examination of the bovine ruminant, discuss some common diseases, some antibiotics, where do they work, how would we use antibiotics, for example, in the respiratory problems versus problems of the reproductive tract, and also discuss other drugs such as anti-inflammatory agents. So physical examination, common diseases, use of antibiotics, and then of course the use of other drugs. I also would like to bring to your attention two textbooks which I feel will complement this lecture very nicely. They are the Merck Veterinary Manual of the 8th edition and Current Veterinary Therapy, 4th edition by Howard and Smith. Due to the time constraints that we have, you can appreciate that food animal medicine is a very diversified subject. We need to discuss diseases in sheep, diseases in swine, diseases in cattle. So consequently, I am just going to review or make mention of some of these diseases, and I think that you can certainly review them in these two texts. I'd like to begin with the clinical examination of the ruminant, of dairy cows or beef cows. And this is very similar to small animal or the equine patients with some slight differences. It is important to obtain a history. Remember that a lot of our history deals with a farm situation, the environment that the animal is in, what type of a diet. We want to perform a thorough examination, just like in the small animal patient, and the proper ancillary tests, CDCs, differential chemistries, bacteriological cultures, etc. The difference, of course, is that we have usually a monetary constraint when we deal with these animals. The expense of these diagnostics procedures may outweigh the benefit. This is why it's very important to try to perform as thorough physical examination as possible. I always remind the students that the most important thing that you can do when you do a clinical examination, when you do a physical exam of a patient, is to arrive or determine the correct diagnosis. If we can do that, we can always find the latest treatment. We can always consult with someone that perhaps is an expert in treatment of that disease. I also say that most things are missed by not looking than by not knowing. And oftentimes we fail to do a thorough physical exam and consequently cannot arrive at the correct or the proper diagnosis. Keep in mind that when we deal with food animals, we are dealing, of course, with a herd versus an individual. Remember that a group of individuals compose the herd. Okay? And just like in small animals or the equine patient, we try to follow the SOAP system. S for subjective, that's the history of the animal, the breed, the age, etc. An objective assessment, that's your physical examination, your clinical findings. And then you want to assess the physical findings with the subjective findings and then come up with a plan. So the SOAP approach to small animal and the equine patient also applies in food animal medicine. As part of a physical exam, we take the temperature, just like in other species, the pulse, the respiratory rate, and rumen contraction. It is a very important component of the physical exam, rumen contraction. If a cow is sick, the first thing that will happen is she goes off feed and she doesn't eat. Consequently, her rumen stops working. Secondly is a rectal exam, where we not only examine the reproductive system, but we try to examine the internal organs, and then an udder exams to determine whether or not the cow has mastitis. No physical exam in the bovine patient is complete until we finish a rectal exam and an udder examination. Some baselines that I would like to discuss with you in terms of, first of all, the temperature. The range is anywhere from 100.4 to 102.5 Fahrenheit. In the southeast region, or certainly here in the state of Florida during the summer months, we must be careful because it is not abnormal to find a cow with a temperature of 103, 103.5 due to summer heat stress. But generally speaking, from 100 to 102.5 is considered to be the normal range of temperature in cattle. Pulse, 60 to 84 beats per minute. 60 to 84 beats per minute, pulse or the heart rate. When we go below 60, then we consider the animal to have a bradycardia. Certainly greater than 84 beats per minute, then we consider a tachycardia. Respiration, or the respiratory rate, 15 to 35 breaths per minute. 15 to 35 breaths per minute. Rumen contractions, excuse me, rumen contractions, 1 to 2 contractions per minute. And we want to characterize them. Are they weak? Are they strong? Okay, rumen contractions. And then a urine collection. Urine sample tells us a lot about the clinical state of the ruminant patient, particularly in dairy cows. We can observe the presence or absence of ketone bodies in the urine. We can also assess the urine pH, blood, glucose. So we want to collect a urine sample as part of our physical examination. The most common way to collect urine in cattle is to massage the escutcheon area. Escutcheon, E-S-C-U-T-C-H-E-O-N. This is the area below the vulva and to the udder attachment. So below the vulva to the udder attachment is considered the escutcheon, and we simply massage it. We simply go right below the vulva and massage this area, and the cow usually urinates. If not, then we can catheterize the bladder with the use of a Foley catheter. I think it's important to develop a systematic and consistent approach. I like to begin with the left side, then examine the rear of the animal, the right side, the head, the udder, and then lastly perform a rectal exam. It's important to do the rectal exam last, because if you do it at the beginning of the examination, there may be some gas that is trapped in the rectum, and that may affect when you auscultate and percuss at the same time. So on the left side, we have the heart, and basically here, what we look for is, can we hear the heart? Can we hear the heart sounds? Normal rhythm. Any abnormal heart sound, such as a murmur. The lungs, we want to be able to hear inspiration. Is there any crackling? Is there any wheezing? Do we have difficulty listening to the air during inspiration and expiration, or the so-called increased bronchovesicular sounds? Then we want to examine the rumen and the abdomen. Remember the paralumbar fossa. Okay, the paralumbar fossa, which on its dorsal border, it has the transverse process of the spinal cord. On the cranial border is the last rib, and then the caudal border, the caudal ventral border of the paralumbar fossa, then is the tendon of the internal abdominal oblique and the transverse muscle. So when we examine the rumen of the abdomen, again, we want to listen for rumen contractions, and we want to also examine on the left side as well as on the right side what we normally refer to as ping, P-I-N-G, and this is simultaneous percussion and auscultation of the abdomen, and it's usually from the last rib, 13th rib, up until the 8th rib. Okay, and basically we put our stethoscope on. Okay, with the head of the stethoscope, we auscultate this area and percuss at the same time. And what we want to hear is the rebound or the echo of any gas-filled organ, such as the rumen, the abomasum, or the intestine. And the sound that it makes, if there's a gas-filled organ, is a ping sound or a metallic sound. And then, of course, we want to evaluate whether or not the rumen is full with gas. From the rear, we want to examine the contour of the abdomen. What is the appearance of the abdomen of the animal? Does it have a so-called pear shape or apple shape appearance? We want to rule out whether the animal has a vagal indigestion, and what type of discharge is from the rectum, from the vagina. We want to look at the area of the escutcheon. Is it soiled? Is it dirty? Is there a purulent discharge? Is there a bloody discharge? So we want to make this assessment while we're doing the physical examination. From the right side is similar to the left. I just want to remind you, the most common murmur occurs on the right side of the heart in the tricuspid valve. We also want to examine the lungs, of course, the abdomen, again, the paralumbar fossa, and in cranial to the last rib. We still want to do simultaneous percussion and auscultation and determine whether or not there is gas distension. In the head region, we want to examine in the head area, the attitude of the animal. Is it depressed? The eyes, what kind of discharge? Is there a discharge present? Is it a mucopurulent or a serous or a bloody discharge from the eyes? The nares, the mouth, we want to examine the mucosa, the tongue, the pharyngeal region, the jugular vein. Is there a distension of the jugular vein? And is it pulsating? Normally, on a normal cow, you can just make out a slight distension of the jugular vein. It's about perhaps the size of your thumb. However, in an animal with cardiopulmonary problems, particularly right heart failure, there is a pronounced distension of the jugular vein. Sometimes it's twice the size of your thumb, and the jugular vein is also distending. There's a distension that takes place. And then, of course, we want to examine the lymph nodes, the submandibular lymph nodes and the deep retropharyngeal lymph nodes. With the udder, we want to examine the anatomy of the udder, the suspensory ligaments. We want to examine the udder. Remember that the udder is divided into two halves, and each half has a quarter, so there's 4 quarters, and of course 4 teeth. We want to examine the base of the udder and the teeth for signs of inflammation, any reddening, swelling, pain, firmness. Those are signs of inflammation in the udder, which are characteristics of mastitis or infection of the udder. We want to evaluate the secretion from the quarter. How different is the secretion from normal milk? Is it watery? Is it bloody? Is it purulent? Then, of course, we want to perform some ancillary tests, such as the California mastitis test And what this test determines is the amount of somatic cells. Somatic cells. And somatic cells include white blood cells and epithelial cells from the mammary, from the lacteal tissue. It does not measure bacteria. The California mastitis test measures the somatic cell count of the udder. Then we can do a specific bacteriological test to determine whether we're dealing with gram-negatives, gram-positive bacteria. The rectal exam, which is the final component of the physical exam, we want to examine the rumen to determine if it's gas distended or not, or if it contains normal feed. Is there any visceral distension? Can we palpate and enlarge large bowel, the cecum, or sometimes even the abomasum if there's a right torsion of the abomasum? So we want to be able to make sure that there are no gas distended bowels on the rectal exam. The lymph nodes, particularly the internal lymph node, the internal iliac. This is a common site for lymphosarcoma. This is also in cows that have chronic nephritis or mastitis. You often see an enlarged iliac lymph node. With the uterus, and of course here we're checking to see whether or not there is a nephritis present. Check the ovary, and it's important to check the consistency of the manure. The consistency of the manure. Is it watery or diarrhea-like? Is it mucoid? Is there an absence of manure? You have an animal that is sick, it's febrile, it's not eating, and you perform a rectal exam, and there is no manure in the rectum. That may be an indication that the animal is having difficulty in passing ingesta from the forestomach to the small intestine. And then, of course, we want to arrive at a differential diagnosis, whether we're dealing with a metabolic disorder, respiratory cardiopulmonary disorder, gastrointestinal diseases, musculoskeletal, ocular, infectious, or toxic. So what I'd like to do now is to discuss with you some of the most common disorders, diseases in cattle, and I would like to begin with metabolic disorders, metabolic diseases. This is particularly in dairy cattle. The three most common ones that we must understand include milk fever, or parturient paresis. A better term is hypocalcemia parturient paresis. Grass tetany, which is a hypomagnesemia. Acidonemia or ketosis. And these two terms sometimes are used interchangeably. Most clinicians refer to it as ketosis. Let's turn our attention to milk fever or parturient paresis. Basically, what this is, there is a failure of hypocalcemia compensation. Failure of hypocalcemia compensation near parturition, near calving, at the time of calving or 24 to 48 hours after calving. There is a tremendous amount of calcium that is lost from circulation into the udder as the cow is making colostrum, as she's manufacturing colostrum. So consequently, a hypocalcemia occurs in these animals, and the cow, there is a failure of the hypocalcemia compensatory mechanisms to take over. Basically the parathyroid hormone and vitamin D. But what I want you to remember that the etiology of this condition is not a deficiency in parathyroid hormone or a deficiency in vitamin D, in either of these hormones. The etiology, there is a failure of the hormonal receptor complex to initiate an effect. So it's a failure of the parathyroid hormone or the vitamin D hormone uniting with the complex, with its receptor, and forming the proper complex. It's an acute milk fever. It's an acute imbalance of calcium at or close to parturition. Normally in dairy cattle, blood calcium is anywhere from 8 milligrams per deciliter to 9 milligrams. Some textbooks, they go a little bit higher than that. When we start having a problem is when the calcium concentration gets below 8. So anytime we deal with a calcium concentration below 8, we may have the clinical form, which is when the cow becomes paretic, she's recumbent, unable to rise, or we may have the subclinical form. And the subclinical form deals with those organs that also have smooth muscle function, such as the rumen, such as the abomasum, and the uterus. The most commonly occurs in older cows, 3, 4, 5, 6 lactations, and again the reason is because these animals tend to have a lower number of receptors for vitamin D and the parathyroid hormone, and is also most commonly seen in the Jersey breed of cattle versus the Holsteins, the Jersey versus the Holstein. Cows that are predisposed to milk fever are those animals that are in a high calcium diet, and part of the theory is that you may suppress parathyroid hormone because they're eating too much calcium. But a newer concept of the etiology of this disease is the fact that many of these dairy cows, before calving, that is, during their dry period, the 3 weeks before they calve, 3 to 8 weeks before they calve, they're eating a diet which is high in cations, that is, in sodium and potassium. And what this does, this predisposes the cow to an alkaline status instead of a more normal. There tends to be more of an alkalosis in condition, an alkalotic condition. And what this alkalotic condition it does, it suppresses this buildup or this upregulation of the receptors for the parathyroid hormone and vitamin D. The clinical signs include recumbency, usually sternal recumbency, low temperatures, decreased heart sounds with a decreased heart rate. There is some rumen stasis and maybe some bloat. And the reason why there is some rumen stasis is because, again, the rumen is an organ that has large smooth muscle component. If there is hypocalcemia, the rumen simply won't contract. Now, with the subclinical form of milk fever, these are cows whose calcium concentration is below 8, but yet the concentration is not low enough to predispose the cow to paresis or to make the cow recumbent. But these cows that the calcium concentration is below 8, yet they don't present with the clinical form, are predisposed to prolapse of the uterus, uterine prolapse, retained fetal membranes, displacement of the abomasum, metritis, and also maybe even some ketosis. So remember that there is a subclinical component. This is a picture of a cow with milk fever. She is on sternal recumbency. If you could examine her iris, it's dilated, or the pupils are dilated. Sometimes they present with what they call this common S-shaped position of the neck because the cow, because of the weight of the head, and then the flaccidity in the neck muscles. If you stand on top of if you can view the cow from the top, you would see the so-called S shape of the neck. Some of these animals are trembling. They're not in tetanic spasms. Okay, this is a difference from eclampsia in the ditch. Okay, eclampsia in the ditch, we have tetanic spasms, not with milk fever in dairy cows. With milk fever in dairy cows, what we have is a flaccidity of the major muscle groups. But there may be some fasciculations and there may be a little bit of trembling going on. But this animal, if she's not treated promptly, they usually die from respiratory failure or heart failure. The treatment, of course, is to relieve the hypocalcemia. And the most common treatment is a calcium borogluconate solution given intravenously, slowly, and this provides about 10 grams. So 500 mLs of a 25% calcium borogluconate solution provides about 10 grams of calcium. And this is what we need to correct the hypocalcemia. We want to monitor the heart for acceleration, double beats, etc., or a low or a decrease in the heart rate and the speed. So when you give the calcium treatment, you must give it slowly and auscultate the heart as you're treating the animal. Prevention, we want prepartum diets that are low in calcium, at least 20 grams per day. This may be difficult because our roughages are usually high in calcium, but the latest prevention scheme for milk fever includes feeding more anions, more sulfur and chlorides in the diet. In other words, you formulate a ration that includes an anionic salt. These are salts high in sulfur and chloride in relation to the cations sodium and potassium. What this does, then, you promote a compensatory acidosis. The cow enters a compensatory acidosis, and basically what happens is before she calves, she has higher calcium in the blood, basically driven by a higher vitamin D production. So the latest technique that we use on dairy farms to reduce the incidence of milk fever is to feed these anionic diets, which are high in sulfurs and chloride. We also, conversely, we want to feed diets that are roughages that are low in potassium and sodium. Remember that the higher the cations concentration in the diet, the more you predispose the cow to an alkaline metabolism, and that will suppress the receptors that are needed for calcium homeostasis or calcium compensation. Then we want to avoid legumes in prepartum cows because they're high in potassium. The next metabolic disorder is grass tetany or hypomagnesemia. Grass tetany occurs more commonly in beef cows in early lactation that are grazing in spring or fall lush pastures with high potassium, sodium, nitrogen, and low in magnesium. Magnesium, of course, is needed for nerve conduction, muscle function. And I also would like to include that magnesium is needed as a cofactor in calcium metabolism. For calcium to be absorbed through the intestine, through intestinal absorption, for calcium to be resorbed from the bones, calcium resorption, magnesium is required as a cofactor. Consequently, if an animal is in hypomagnesemia, they can also mimic hypocalcemia or milk fever. The blood levels depend on the daily intake because there's very little storage of magnesium in the tissues, such as the liver. The normal blood magnesium is about 1.7 milligrams per deciliter. Clinical signs usually occur when they're below 1.2 milligrams per deciliter. And again, it's often accompanied by hypocalcemia and hypophosphatemia. And the reason for this, again, is because they're needed as cofactors for normal calcium and phosphorus metabolism. What are the risk factors for grass tetanies? These are cattle that are grazing in fast-growing pastures such as oats, rye, particularly after rains. Oats and rye are considered winter pastures, and during the rainy seasons in certain parts of the country, in the southeast and out west, we have these pastures that grow rapidly, and they actually have low magnesium content. Basically what happens, there is a reduction in magnesium intake. If we have diets that are high in potassium, such as some of these legumes, it interferes with magnesium absorption, so the higher the potassium may affect magnesium absorption. If an animal has diarrhea, for example, from an infectious source, that can also affect the magnesium absorption. The clinical signs. The clinical signs are similar to milk fever cow, except that now we have hyperexcitability, tetany, we have tonic-clonic muscular spasms. The key here is spasms, convulsions, and death. If you compare this disease to milk fever, what you see with the milk fever cow, with the hypocalcemia cow, is a recumbent animal that there is flaccidity in the major muscle groups, flaccidity. With hypomagnesemia is tetanic spasms, tonic, clonic, muscular spasms, almost similar to the ditch in small animal medicine with eclampsia. And this is just a picture of a beef cow, of a Hereford cow with hypomagnesemia. And if I were to show you this in a movie or in a tape, you could almost visualize the spasms, the head jerking, the rigidity and contraction of the muscle, of the major muscle groups. Treatment is 500 ml of a 25% calcium borogluconate solution, because remember that these animals they also have a hypocalcemia component, so we want to also take care of the calcium deficit, and we want to have about 5% of magnesium in a hypophosphate solution. There is a solution which is called CMPK. It's one of the most popular brands hypocalcemia solutions, which contains calcium, magnesium, phosphorus, and potassium, and it's balanced for these disorders. So if you suspect a cow with milk fever, you can use this product, and you can also use this product if the animal has hypomagnesemia, because it has enough magnesium to bring the magnesium concentration to normal. How do we control this disease? We want to make sure that we provide enough magnesium in the diet of milk cows, about 20 grams per day. We want to feed magnesium salts to animals that are grazing under conditions at risk. And we want to avoid high potassium fertilization. We certainly don't want to bring cows into a pasture 1 week to 10 days after a high potassium fertilization, because remember that the potassium will affect magnesium absorption. The third metabolic disorder, which is quite common, and it's one of tremendous economic importance to the dairy industry, is acidonemia or ketosis. And the reason why this disorder is of such economic importance is for three reasons. One, the animals may die. Okay, so there's the cost of the death of the animal. Secondly, those animals that survive after they're treated will produce less milk. They tend to produce lower milk during their lactation. And third, that the reproductive performance during that lactation is also compromised. These animals tend to be less fertile. It takes them longer to become pregnant. So let's take a look at the etiology and the clinical signs of acidomania. Basically, what happens is that feed intake cannot meet the energy demands during early postpartum. The animal cannot eat enough to maintain the energy requirements to produce milk. Consequently, there's a loss of body weight, there's a decrease in milk yield, and the ketone bodies appear in the urine and milk. So the animal, the cow, is in a ketoacidosis. The dairy cow is in a ketoacidosis because she simply cannot get enough energy. And I want to remind you the three ketone bodies: beta hydroxybutyrate, acetoacetate, and acetone. These are no different than the bitch or the dog with diabetes. Okay, these are the ketone bodies. As a matter of fact, if this is a condition in dairy cows which is similar to diabetes in dogs. The difference, of course, is that in ketosis in dairy cows, there's not a problem with insulin. Okay. I would also want to remind you, while we're discussing acetoacetate, that one of the ways that we diagnose this condition is we take a urine sample using a multi-stick or an individual tablet to check for acetoacetate in the urine, and the reagent it's a nitroprusic acid, and when it interacts with acetoacetate, it causes a buff pink or purple discoloration, and this is called the Rothera test. So keep in mind then that the Rothera test determines acetoacetate in the urine, and if it's present, it will change to a deep purple discoloration. Okay, you may not be able to see this figure very well, and I apologize for it, but let me kind of walk you through what happens in the dairy cow or beef cattle during parturition. So here in the x-axis, we have days relative to calving, and on the y-axis, we have dry matter intake in pounds per day. What I want you to notice is the relationship of dry matter intake during the prepartum and the postpartum period. So before calving, okay, which is this time here, the animal is usually fed a different ration. She's in her dry period, and I want you to notice that her dry matter intake begins to decline a little bit. It can go as high as 30%, but it can go as low as 5%. So anywhere from 5 to 30%, her dry matter intake begins to decline prior to parturition, which is here at day 0. And the reason that this happens is because of the hormonal changes that are taking place after near parturition. Now the cow calves. She undergoes parturition. And I want you to notice that her dry matter intake, her appetite and dry matter intake begin to increase on a gradual basis. Okay, on a gradual basis. And this dry matter intake does not peak until 10 to 12 weeks after calving. So the first 10 weeks after parturition, the cow is eating more until she peaks. What happens, however, is that her peak in milk production occurs at about 6 to 8 weeks. So peak milk production occurs prior to peak dry matter intake. Consequently, the cow, in order to meet those challenges, that challenge to produce the milk that she is genetically programmed to do, must mobilize fat or must use body reserves to maintain energy balance. And consequently, she loses weight during this first 2 to 3 months postpartum. There's a wasting condition. This is a wasting condition where there's a gradual decrease in appetite and milk yield. There's rapid loss of body condition, and the animal may be moderately depressed. There's a nervous form, which is the most severe form of ketosis, is the ketoaciduria. It may be caused by the ketoaciduria, and it is also caused by the hypoglycemia, because this is a hypoglycemic condition. So with the nervous form, which is the most severe form, we have vigorous movements. Some of these animals tend to lick the skin or inanimate objects such as the pipes. There's a depraved appetite, chewing movements with tremendous salivation. The animal may walk in circles and may even appear to be blind, disoriented, stargazing, sometimes they call it. And the subclinical form, which is not as bad as the severe, the animal enters into what we call a negative energy balance. Ketones are present in the urine and the milk, but there are no clinical signs. Okay. When the animal's in this negative energy condition, basically what happens, the hypothalamus and the ovaries shut down, and the animal does not cycle. The animal does not begin to cycle postpartum. Perhaps the most common cause of ketosis is a secondary form. And the reason why we call it secondary is because as a result of any disease that causes a cow to eat less, lower appetite during early lactation. So any disease, any disorder that may affect the dry matter intake, that lowers dry matter intake in dairy cows, also predisposes them to ketosis. And which are they? Let's think about this for a second. What diseases can we see during the postpartum period or days in milk that may affect the ketosis? Well, it could be less displacement of the abomasum, which I'm going to talk about in a few minutes, metritis, an infection of the uterus, mastitis, which is, of course, like we discussed, an infection of the mammary gland, or it could be poor management, that there's simply too many cows for the feed trough, or a ration that has not been properly balanced. So any condition that causes the cow to go not to eat, like febrile condition, or an improperly balanced diet, can also predispose the cow to secondary ketosis. The treatment, basically the treatment is aimed to correct the hypoglycemia. This is a hypoglycemic condition. 500 to 1,000 mLs of a 50% glucose or dextrose solution. Glucose is the enantiomer of dextrose, but we could use either. Or we can use propylene glycol, 200 mL twice a day on the first day, then 100 mL once a day for 2 or 3 days in a row. Why propylene glycol? Well, propylene glycol is converted to propionate in the rumen. propionate being one of the volatile fatty acids, and 50% of the glucose in ruminants is derived from propionate. So consequently, when you give propylene glycol, the propylene glycol is converted to propionate, and then that's how you can help restore the glucose. We can also use dexamethasone, 25 milligrams, and this basically has peripheral use of glucose is reduced to increase the acetyl-CoA utilization. Acetyl-CoA utilization, so the acetyl-CoA can enter the TCA cycle, the Krebs cycle, and that can then the cow can then produce more glucose that way. So it's a very interesting mechanism that involves the Krebs cycle and acetyl-CoA. So the dexamethasone or the steroids basically has a glucose-sparing effect on peripheral tissue, such as the mammary gland, and more glucose then is available for the liver, and more glucose is available for adipose tissue, and consequently then the acetyl-CoAs are used. How do we control or prevent this condition? We want to avoid over-conditioned or over-fat cows. Cows that are over-conditioned tend to eat less prepartum and postpartum, and consequently are more predisposed to ketosis. We want to avoid feeding poor quality silage that is high in beta-hydroxybutyrate that may be ketogenic. And we want to maximize dry matter intake post-calving. This is perhaps the most important one right here. When we manage dairy cows, we want to have their cow comfort. We want to have their nutrition well established, so that as soon after calving, the cow can start to maximize her dry matter intake, because she begins that gradual increase in dry matter intake to prevent ketosis. So this is nutrition management, how we prevent this disorder. I would now like to switch and discuss a little bit the respiratory and cardiopulmonary disorders. The first one is the bovine respiratory disease, which is also, or bovine respiratory disease complex, which is also referred to as shipping fever in some textbooks. This is a common feedlot disease, but it can also occur in dairy herds. It's a condition of the host, an agent, and the environment. Basically what happens here is we have a stressful situation. We have a stressful condition. Proper nutrition, proper environment, too hot, too cold. So the animal is stressed. Secondly, we have a viral insult to the animal. Third, we have a bacterial component. So it's stress, virus, bacteria. And this is commonly referred to as a host, agent, and environment condition. It usually occurs 10 to 14 days after the stress, for example, in feedlot cattle in transport, or in dairy cows after parturition. And the agents, the more common agents, are the viruses, IBR, infectious bovine rhinotracheitis, PI3, parainfluenza, 3 virus, and BRSV, the bovine respiratory syncytial virus. And perhaps another one is BVD, bovine viral diarrhea. So these 4 viruses, along with these 3 bacteria, Pastorella, Mycoplasma, and Haemophilus, are the most common agents involved in the bovine respiratory disease complex. Clinical signs: early, the animal may go off feed, depressed, rapid shallow breathing. There may be a serous nasal discharge with a moist cough. As the condition progresses, we have a febrile condition, deep labored respiration, dyspnea, both during inspiration and expiration. And we may see a purulent ocular nasal discharge. So this is a progression. This is a progressive disease from early signs, middle to late. At the beginning of a respiratory problem, you may have a fever. The animal may have a fever of, say, of 103.1. You may have difficulty hearing inspiration and expiration. There may be a serous, watery discharge from the nares. Later on, end stage, or at the latter part of this condition, then you may have an animal with a higher temperature that now has a more purulent discharge from the nares, and you can unequivocally hear wheezing, crackling, or harsh lung sounds. So this is a disease that is progressive from its early stages to the latter stages. Treatment of this condition, of course, is with antibiotics, and we'll talk a little bit more about that in my last slide, about which antibiotics are the most common ones that are used in cattle. And the key to this condition is its control. As it often is in food animal medicine, control of or prevention of the disease is more important, at least from an economical perspective, than treatment. So obviously, if we start having animals that have begin to show signs of a respiratory component, we want to separate these animals into infected herds so that they don't contaminate the healthy cattle. Early identification and treatment of affected animal, I think, is critical. The earlier we can identify this disease and treat the animal, the higher the recovery rate. And then if there is an outbreak, meaning that more than 20-30% of the herd is affected with respiratory problem, of course, we want to mass medication through the feed, or with an antibiotic through the feed. Prevention, as I said, is the key. And what we want to do with prevention, if we go back to the etiology, we want to cut down the stress, reduce the stress as much as possible, try to arrive at a stress-free environment. So we want to minimize any rapid changes in temperature and humidity through proper building design and construction. We want to have an adequate nutrition that is high in protein, energy, vitamins, trace mineral, ample drinking water that is fresh, clean, adequate ventilation. This is very important. As ammonia builds up from the urine in some of these barns, that can affect the lungs, and it can irritate the lung and predispose the animal to viral infections and bacteriological infections. And we want to provide then ample ventilation. And vaccination here is the key. This is a preventable disease. And what do we vaccinate for? Well, we vaccinate for IVR, BVD, PI3, BRSV, Pasteurella, and Haemophilus. And usually we have a scheme of vaccination that begins when the animal is young as a calf, and then vaccinate every 3 months, including when the animal is as a milk cow, or even when the animal is in the feedlot. And that's what this word backgrounding means. This word backgrounding is used for beef cattle, and basically what we want to do before the animal arrives to the feedlot, we want this animal with the proper nutrition, with a proper vaccination scheme. Pasteurella is one of our bacterial agents. Pasteurella hemolytica is the most common. And also, Pasteurella multocida is an acute bronchopneumonia with toxemia There's usually an antroventral exudative pneumonia, and is secondary to viral, weaning, and other stressors. Cannot overemphasize this word right here, stress. Anything that stresses a calf or a cow. Then we have a secondary, then we have a viral insult, and then it's followed by a secondary infection, which is, in this case, would be Pasteurella. The clinical signs are similar to what we just mentioned. They're usually respiratory or pneumonia-like, and the treatment, antibiotics, such as an oxytetracycline, ceftiofur, sulfa drugs, fluoroquinolone. Any of these antibiotics can work. And then, of course, a proper vaccination program, that the animals are vaccinated early when they're young, and then that a scheme is respected, a sequence of vaccination every month, every 2 or 3 months is respected. And whether or not you're using a replicating versus a non-replicating vaccine, and there is some disagreement amongst the experts as to which vaccine is more efficient. So certainly we want to try to prevent this disorder, and we do so with the proper management of the animal, and then with vaccination. This is a post-mortem examination. I don't know whether you'll be able to appreciate, but there's basically a bronchopneumonia, an anterior-ventral bronchopneumonia. Anterior-ventral bronchopneumonia, which is commonly seen in these animals. Infectious bovine rhinotracheitis, IBR. You may have had a lecture on this already by Dr. Gibbs, but I just want to review some components here as they relate to food animal, at least cattle. Remember, it's a herpes virus 1. It's highly infectious. It may present with various components: a rhinotracheitis, a conjunctivitis, fever, with an occasional meningitis in calves. Remember that there is a vaginal or a reproductive component. In females, it may cause a pustular vulvovaginitis, and it may also involve abortion. So it's not just a respiratory complex, but it can also involve abortion and present as pustular vulvovaginitis. In bulls or in males, the component to the pustular vulvovaginitis is infectious balanopostatitis, IBP, infectious balanopostatitis. And again, it's an important as primary infection preceding the Pasteurella bacteria. Treatment for Pasteurella is antibiotics, supportive treatment, and vaccination, as we have been talking about. Haemophilus somnus. Haemophilus somnus has a reproductive form as well as a respiratory form. The reproductive form may cause vaginitis, endometritis, infertility, and abortions. Haemophilus somnus. The respiratory form affects the upper and lower respiratory tract. It may lead to a laryngitis or a tracheitis, as well as a suppurative bronchopneumonia with severe fibrinous pleuritis. Okay, so this tends to be a little bit more aggressive, a little bit more angrier, if you will, than the Pasteurella type pneumonia. But don't forget that there is a reproductive form, and there's also a respiratory form. Haemophilus somnus, the septicemic form, may localize in the brain, the heart, joints, liver, and kidney. So we have respiratory, reproductive, and then a septicemic form. The clinical sign, if the brain is affected, is referred to as thromboembolic meningoencephalitis, TEM, thromboembolic meningoencephalitis, TEM, which is a more common disease in seen in feedlot cattle. Okay, and this presents with high fever, profound depression, and neurological signs, recumbency, and death. And this is just a slide from the brain of an affected animal with TEM, the thromboembolic meningoencephalitis, so that you can appreciate the meningoencephalitis component of the brain, TEM. Let's now switch to the most common cardiovascular diseases in cattle. A common one is traumatic reticular peritonitis or pericarditis, because it may cause a pericarditis, and it may also cause a peritonitis. And the common name for this is hardware disease. Hardware, because the animal usually ingests a piece of wire or a nail. There's a metal foreign body, which is usually greater than 5 centimeters, is ingested, and it may lodge in the reticulum, the reticular wall, usually during parturition or estrus. And basically what happens is that this foreign object, this wire or this nail, basically penetrates the reticular wall or the rumen wall, and it may extend into the diaphragm, or it may penetrate through the diaphragm and lodge itself into the pericardium. So it can manifest itself into different situations. Okay, it could just barely attach or penetrate the reticular wall. It can penetrate the reticular wall and into the diaphragm, or it can go through the diaphragm and actually puncture, if you will, the heart, and then cause a pericarditis. So it may cause a localized peritonitis with adhesions. The foreign body may continue migration to the pericardium, resulting in a pericarditis. The clinical signs: at the beginning, milk production is lower. The animal may be febrile. It's positive on the pinch test. That's a test to elicit pain over the withers. In the end stage of the disease, we may hear the so-called washing machine heart sounds. Well, that's the fluid that is accumulating around the heart, around the pericardium. And during heartbeats, the fluid is moved back and forth, and we get the so-called washing machine sound. As the condition progresses, we go into a right heart failure, and we begin to see some ventral edema, which is associated with the heart failure, and distension of the jugular veins. Remember, I mentioned that earlier in the talk. So we have distension of the jugular vein. Treatment, unfortunately, is not very rewarding. There may be surgery to remove the foreign bodies. You may give antibiotics, but the treatment is not very rewarding. The prevention for this condition is, first of all, common sense. Try to have an environment that is free of these foreign bodies, the nails, the wires, and then provide a magnet. There's a magnet that is given orally to these animals when they're young, so that the metal object can then attach to the magnet. And this is a picture of a necropsy case that we had here at the university some years ago, and you can appreciate this is the nail that the animal ingested. In this case, it went through the reticular wall, through the diaphragm, and then it actually not only penetrated the pericardium, but also the heart itself, and you can see this abscess that was formed. This is the nail that you see here. And of course, all of this is the pericardium. You can appreciate this fibrino purulent condition with fibrin and adhesions. Endocarditis is a second heart or cardiac disorder. Endocarditis is associated with chronic infection at a distant site with a persistent bacteremia. A ruminitis predisposes the animal to liver abscess, and then from liver abscess we have an emboli that goes to the endocardium. We may also have that's the most common one, metritis, some severe form of mastitis, like an E. coli mastitis, or a nephritis. But by far the most common one is a ruminitis that has led to a liver abscess, and then there's an emboli or a showering of the of an emboli that goes to the endocardium and causes then an endocarditis. These are vegetative growth on the heart valves in cattle. The right AV valve, or the tricuspid valve, is the most commonly affected. The tricuspid valve is the most commonly affected. It's also referred to as verrucous endocarditis. Clinical signs: we may pick up a murmur on auscultation and a palpable thrill, distension of the jugular vein with ventral edema, right heart failure. So this jugular vein distension that I mentioned to you is important. When you see that in dairy cows, you need to be thinking of a heart of a wire, or you need to be thinking of an endocarditis, or perhaps some protein losing enteropathy. Treatment, again, is often unrewarding when we have to this stage. We can use antibiotics, diuretics if signs of congestive heart failure occur. A very interesting infectious disease or viral infection disease of cattle that has a heart component is bovine leukosis or bovine leukemia virus. This is a retrovirus, Retroviridae, BLV, and we often discuss this infection when we're talking about the cardiopulmonary system in dairy cows. This is a virus which is transmitted. Transmission could be iatrogenic or possibly via insect vectors, mosquitoes, flies. Any type of insect vector has been shown that may transmit this virus. The most common one is related to iatrogenic, such as needles, palpating sleeves. When we palpate dairy cows to do the reproductive tract examination, if there's a little bit of blood in the sleeve, in the plastic sleeve, we recommend to remove the sleeve so we don't recontaminate or reinfect cows. There may also be an in utero transmission, and 5 to 10% of animals infected develop the clinical disease. Animals with clinical lymphosarcoma are usually greater than 4 years of age. So bovine leukemia virus predisposes the cow to lymphosarcoma, to bovine lymphosarcoma. The clinical signs of lymphosarcoma are dependent on the site of tumor formation. Clinical signs are dependent on the site of tumor formation. Basically, we have 5 sites, so this is a multi-centric condition. We may have the abomasum, which is quite common. Then the heart, the right atrium, retrobulbar, behind the lymph node retrobulbar lymph node, the uterus. This is a common, one of the most common metastatic tumors of the uterus. or the spinal cord. So the clinical symptoms depend on where the tumor has metastasized to. If it's the abomasum, we may get left displacement of the abomasum, the heart, right heart failure, retrobulbar. We may lose the animal because the eye has to be nucleated. The uterus, of course, is a reproductive problem. And if it's a spinal cord, then the animal becomes a downer, paretic cow, unable to rise. How do we control this disease? Is basically we want to separate the calf soon after birth from the dam so that it's not transmitted through the colostrum or through the milk. We want to reduce iatrogenic transmission through proper disinfection. We want to change needles. We want to change needles that we use for vaccination. We want to change sleeves for that we use on rectal palpation. And then we basically want to test and call these animals. There's an AGID test that we use. If the animals are positive and they become, and they present with one of the symptoms from one of the organs, then we basically call and get rid of the animal. This is a horrific picture that I want to show you as the magnitude of this disease. This is an ocular version of lymphosarcoma, and basically this is where the tumor is. It's retrobulbar, it's a retrobulbar lymph node. And what happens is that it pushes the eye out, so there's an exophthalmia, and then we have desiccation, the inability of the eye, of the cow to close the eyelids, and this becomes desiccated, and then we have secondary infection. If this only happens in one eye, then we can go ahead and do an enucleation, but in this case it was bilateral. But when you see an animal like this, okay, in one eye, don't forget that you need to be looking for other, for lesions, for tumor lesions, either in the abomasum, the heart, the uterus, because again it's multi-centric. I'd now like to move on to some of the most common gastrointestinal disorders, and this include actinobacillosis, actinomycosis, bloat, ruminal acidosis, abomasal disorder, salmonella, and then Johne's disease. Actinobacillosis, this is caused by Actinobacillus ligneriaceae, is also referred to as woody tongue. The actinobacillus enters through soft tissue lesions, and it causes a granulomatous abscessation, and the tongue is the most commonly accepted. So there's some granulomatous abscessations in the lung. Sometimes you can also see it in the buccal mucosa around the cheeks, and it's mostly soft tissue. This is Actinobacillus ligneriaceae, and is due to trauma. A piece of wire, a piece of weed, or a rough piece of hay, or sometimes iatrogenically, if we are using a bowling gun and then we damage this the mucosa. So the clinical signs are salivation. There may be some mandibular swelling with weight loss. We make the diagnosis through clinical signs, biopsy, and examining the tongue, see for evidence of the granulomatous lesions as well as pus. The treatment, oxytetracycline, penicillin, and sodium iodide. Sodium iodide. That probably would be my first choice. Sodium iodide. A similar disease is called lumpy jaw or actinomycosis, and this is caused by Actinomyces bovis. Same etiology enters through wounds in the buccal mucosa or the dental alveoli, causes a very fine osteomyelitis of the bones of the head, including the mandible. It's a painless bony swelling that may break through the skin and discharge small amounts of pus may be seen. The diagnosis is the clinical signs, culture, and the so-called sulfur granules. Sulfur granules that you see from the actinomyces. Treatment, if there are advanced cases, are unresponsive. Early treatment with antibiotics and again iodides may resolve infection, but bone changes may remain. And this is a picture of, you can see the protrusion through from the internal, external protrusion. And if you treat these cows early, they may continue to be productive animals. So this is woody, I beg your pardon, this is lumpy jaw or actinomycosis. Bloat, ruminal distension. This is quite a severe form. Of course, the rumen is on the left side, but it's so severe that has also extended and affected even the abomasum, which is on the right side. And sometimes the bloat can be so severe that that even part of the rumen may still come out on the right side. Bloat or primary bloat is associated with the ingestion of legumes or grain. Pasture bloat versus feedlot bloat. And is the production of a stable foam in the rumen that traps the gas. Saponins from some of these legumes may block combine with the gas, okay, and it may prevent the gas from being eructated or from being relieved, because it forms a very stable complex. Remember that death in these cases is due to respiratory failure. Treatment, if it's not an end stage, if it's not very severe, we simply pass a stomach tube to relieve the gas. We can add some mineral oil, okay, or we can, which act as a surfactant. There's a proloxone, which is a surface active agent, which basically acts as a surfactant, and it dislodges or dissolves the complex of the saponins with the gas, and now the animal is able to eructate. If it is severe enough, we must do an emergency rumenotomy if the condition cannot be relieved by stomach tube. So, animal that is bloated, you pass the stomach tube, try to relieve the gas. If that doesn't work, then you can give some mineral oil, or you can give a surface active agent, and that will dislodge, will dissolve the stable saponin with the gas, and that will allow the animal to eructate and get rid of the gas. If that is not successful, then an emergency rumenotomy will have to be done. Secondary bloat, that was primary. The secondary bloat is failure of eructation due to physical interference, a mass in the mediastinum. Foreign body stenosis from the outside, such as in the esophagus, from an enlarged mediastinal lymph node, or obstruction of the cardiac of the rumen, such as you may see in actinobacillosis. So this is referred to as secondary bloat. Diagnosis is based on the history, physical exam, and passing of a stomach tube. Treatment, depending on the cause. If it's a chronic condition, we may use a rumen fistula in chronic bloaters. The second condition is ruminal acidosis. Ruminal acidosis is caused by an ingestion of large amount of highly fermentable carbohydrates when rumen is not adapted. There's too much concentrate, too much fermentable carbohydrates in relation to fiber. And this usually occurs after parturition. When a cow is coming from a dry cow, a dry cow diet to a milk cow or a producing or lactating ration. So the rumen is not adapted. The rumen has not adapted to receive high amounts of fermentable carbohydrates. So there's changes in the microflora occur with an increase in Streptococcus bovis and Lactobacillus. So these fermentable carbohydrates start lowering the pH, and consequently Strep bovis and Lactobacillus bacteria predominate, and they produce lactic acid. This bacteria produce lactic acid. Lactic acid then lowers the pH even further, killing the protozoa that are in the rumen, and now we basically have a dysfunctional rumen. The lactic acid is absorbed across the rumen wall, and this leads to a systemic acidosis. The animal may be off feed with a full rumen and abdominal pain, heart rate is increased, and there is a profuse pale gray-yellow diarrhea, and dehydration, recumbency, and death. And when you do a rumen pH in these animals is usually less than 5.5. So it's a lactic acidosis because it's absorbed from the rumen, and then we have an increased heart rate. The animal may have a yellowish gray diarrhea, abdominal pain, dehydration, eventually recumbency, and death. The treatment for this condition is to provide free access to hay, as much hay as possible, because remember that the hay will act as a buffer, okay, because it will produce the so-called rumen scratch factor, and it promotes salivation, and the saliva is very high in bicarbonate. So that's one way that we can help cows in the initial stages of this condition. And then we want to have a gradual reintroduction of grain. We can treat with an oral sodium bicarb, about 130 grams 3 times a day, orally, or in severe cases, intravenous sodium bicarbonate, then with an isotonic fluid with non-steroidal anti-inflammatory agents. So there's an intravenous sodium bicarb, isotonic fluid, and non-steroidal anti-inflammatory agents. This is an emergency treatment. We must act quickly to rehydrate the animal, control the acid-base balance, and then offer some buffering relief to the rumen. The prevention for this condition is, again, it's good nutrition, providing a well-balanced ration, particularly after parturition. Abomasal disorders, the left displacement of the abomasum, referred to as LDA, left displacement of the abomasum. This is a multifactorial condition. It's caused by a number of factors. It originates from an apnea of the abomasum, so failure to proper contraction of the abomasum, may be related to metritis or mastitis. Any condition that produces toxins affects the pyloric outflow of the abomasum in cattle, and consequently the abomasum distends and it doesn't contract as well. Hypocalcemia, as I mentioned earlier, the abomasum has smooth muscle function, so if the animal is hypocalcemic, this is a subclinical form of hypocalcemia. And then there's poor contraction, apnea, and then the abomasum can displace. Ruminal acidosis can also predispose to LDA, usually occurs 4 to 6 weeks postpartum. 4 to 6 weeks postpartum. Clinical signs: the animal is off milk or low milk production, may be ketotic, decreased movement, and a left-sided ping. This is what I was referring to earlier. You hear a left-sided ping. Basically what happens, remember the anatomy, that the abomasum is on the right side of the cow. It distends for the reasons that I mentioned. The cow is off feed. So the rumen is small. Abomasum gets distended with gas, simply moves medially underneath the abomasum and displaces into the left side. So left displacement of the abomasum. And then when we do our physical exam, we put our stethoscope on and we go in front of the last rib on the left side and percuss at the same time that we're listening with the stethoscope, and we hear this tympanic or this metallic sound, and that's what we refer to as a ping. Treatment: surgery. This condition responds very well to surgery. There is a standing right flank omentopexy. There is a standing left flank abomesopexy. Then there is a paramedian abomesopexy. Probably the most common surgery is the standing right flank omentopexy, where we go in and deflate. We go in on the right side, deflate the abomasum, and then bring it to the right side, and then perform a omentopexy to the peritoneum. After surgeries, we need to treat these cows for glucose, because remember that they're ketotic. Prevention: proper dry cow management and ration balance. This is a condition that is caused in dairy cows that have poor nutrition, that the nutrition management is not very good. We also have a right displace of the abomasum, and this is an emergency. What happens here, same etiology, or we think that is similar to the same etiology, but instead of the abomasum displacing to the left side or going underneath the abomasum, basically what happens is that the abomasum distends on the right side, and it flips or it moves dorsal, not underneath the rumen to the left side, but it pushes dorsally, and it's susceptible to a torsion, okay, or a volvulus. This is similar to the stomach volvulus condition that you see in dogs. Okay, so the causes are not well understood. Is usually in first couple of months post-calving. Clinical signs more severe than the LDA. Cows with LDAs have a metabolic alkalosis, and they're also hypokalemic. Well, the same thing with RDAs, but it's in a more severe form. Treatment, again, is surgically. We do a right-sided laparotomy. We decompress, detorse, and perform an omentopexy. Let me go back for just a second of left displacement of the abomasum. I forgot to mention, again, just want to reemphasize that cows with the left displacement of the abomasum are hypoglycemic. They're ketotic. They have a metabolic alkalosis, and they're hypokalemic. When you do a urine sample in these cows, when you check their urine in these cows, not only will you find that they have ketosis, but they also have an acid urine. And this is very interesting because, as you know, the urine pH in ruminants is on the basic side, 7.8 to 8.0, compared to monogastric such as the dog, where the urine is more on the acid side. Well, what happens in cows with a left displacement of the abomasum, due to the displacement, they're hypokalemic, So the kidney is going to try to conserve as much potassium as possible to maintain electrical neutrality. Consequently, hydrogen ion is exchanged at the renal level, and then what we have is what they call a paradoxical aciduria. Paradoxical aciduria, because here's an animal that has a metabolic alkalosis, yet she has an acid urine. And the same thing can happen, of course, with an RDA. And this is just a post-mortem on a cow that had an RDA, right displacement of the abomasum, with a torsion. This is the abomasum here, and you can appreciate the torsion. This is the duodenum, and this is the constriction right in here. So again, an RDA is an emergency because it's a more serious condition. Salmonella, Salmonella typhimurium, and Dubling. Sources of infection include carrier and infected cattle, contaminated feedstuff, and rodents. Feed that gets wet and is contaminated with manure. Remember that there's a septicemic form, and it's more common in calves. We may have severe depression, and the animal may be prostrate, febrile, and die within 24 or 48 hours. Salmonella, the acute form, again in calves and adult cattle, fever, putrid diarrhea with mucus and blood. Hematochezia. And we also may see abortion from time to time. The chronic form is usually in adult cattle, which is rare, usually follows an acute infection. Chronic diarrhea with occasional blood. Treatment is antibiotics such as sulfa, cephalosporins. We want to separate the animals, and fluids if needed. Johne's disease, okay, Mycobacterium paratuberculosis. This is an important disease that the FDA, the Food and Drug Administration, now has a series of programs in dairy farms to try to control this disease because it's very infective. Spreads via fecal oral route, so a cow that has Johne's disease, that has diarrhea, can contaminate other cows. Calves less than 6 months are most susceptible. The clinical signs of this condition: a chronic diarrhea, loss of body condition, ventral edema due to a hypoproteinemia that is unresponsive to antibiotics. Older cows with a chronic diarrhea, with ventral edema that do not respond to antibiotic treatment, you're susceptible of this condition. And they usually present as animals that are small, beg your pardon, that have lost weight, they're thin, they have a profuse, watery diarrhea. When you visualize, you look at this diarrhea on the ground, it tends to bubble up. It has like some bubbles. And that is due to some fermentation that is taking place in the hind gut. On post-mortem examination, we have a diffuse segmental granulomatous enteritis, which affects the intestine, commonly the distal ileum and the ileocecal valve region. The diagnosis: there is an ELISA test, and there's also fecal smear and fecal culture. So this ELISA is very accurate if clinical signs are present. The control: we want to separate calves at birth so they don't get contaminated from the cow. We want to reduce heifer contact with contaminated pasture. We want to test adult cows and separate or slaughter. So any adult cow that is positive to Mycobacterium paratuberculosis, that presents with diarrhea, that has the clinical signs of diarrhea, if we know that she's positive, it's best to either separate her or call the cow. Call the cow. Send her to slaughter. And again, the most important thing that we can do is try to respect hygiene in these dairy farms in these beef cattle ranches to reduce the fecal contamination from one cow to the next. It's probably the best control that we have. Musculoskeletal diseases. There's just a few here that I want to discuss with you. Downer cow syndrome. Remember that a syndrome is an aggregation of clinical signs from different organs. Downer cow basically is a prolonged recumbency, usually in periparturient cows, 10 minutes after calcium treatment to 24 hours after initial recumbency. So you have a cow that has milk fever, you treat her with calcium, and she doesn't get up within 24 hours. This animal is a danger of becoming a downer cow. A typical downer cow appears bright, alert, and is unable to rise. Occurs between 2 to 10 days after calving. It's a sequelae to parturient paresis. The incidence of the downer cow syndrome increases with the time between the onset of milk fever and initiation of calcium. The longer it takes you to treat a cow with milk fever, the higher the risk of this cow becoming a downer cow. Prolonged recumbency leads to muscle damage, or the compartment syndrome, which affects the biceps femoris or the semimembranosus and semitendinosus. There could also be some nerve damage because the animal is on recumbency, such as the sciatic and the peroneal nerve. Skeletal damage, pelvic fractures, femoral neck fractures, and coxofemoral dislocations can also affect or predispose the cow to the downer cow syndrome. And there's metabolic disorders such as ketosis. There's a decrease in potassium, magnesium, hypomagnesemia or hypophosphatemia can also predispose the cow to the downer cow syndrome. The other predisposing factor is calving trauma. If we have a cow that calves with a big calf that requires a dystocia, that the animal has dystocia, and you deliver the calf with force extraction, and you cause damage to the obturator nerve. So this is also another predisposing factor. Treatment is a good clinical exam so that we can rule out any metabolic disorders. So we can rule out hypomagnesemia, hypophosphatemia, and milk fever. Then we want to provide supportive therapy, adequate bedding, water, and feed. Turn the cow from side to side, okay, so she doesn't stay on one side longer than the other. If possible, float the animal. There are certain devices that you can purchase. Some of these dairy farmers purchase. They put water in it, and they actually float the animal to prevent the compartmentalization syndrome. 50% of downer cows get up within 4 days. Recumbency for periods greater than 7 days indicates a poor prognosis. Control. Here we want to minimize the occurrence of physical injuries such as obstetrics paralysis or obstetrical damage, dislocation of the hip, parturient paresis, or other metabolic disorders. Another musculoskeletal disease is nutritional myodegeneration or white muscle disease. This is caused by selenium deficiency. Diets with less than 0.05 milligrams of selenium per kilogram of dry matter. These cows are predisposed to white muscle disease. There are essentially two forms in young animals. One is the cardiac form. This affects neonates in the first week of life. Acute or peracute severe debilitation, sudden death. The heart muscles are affected. This is commonly referred to as Morley heart disease. Morley heart disease. You see it in pigs, you see it in calves, and in lambs. and is basically a degeneration of the cardiac muscle. The skeletal form affects the diaphragm, the intercostal muscles, and the animal presents with respiratory signs. There's also poor growth with severe debilitation and sudden death. In adult cattle, a selenium together with a vitamin E deficiency, because you're not providing enough, the farmer is not providing enough in the diet, may lead to abortions, retained placenta, mastitis, infertility, stillborn. So any condition that it's infectious diseases, cows that have low vitamin E or selenium in the diet, adult cattle are more predisposed to this condition. Ocular disorders, just want to go over the most common one. Cancer eye, or a squamous cell carcinoma of the third eyelid, or the upper and lower eyelid, most commonly in Hereford beef cattle and Holsteins. There's any animal that has like a white face. Usually develops on the nictitating membrane. The nictitating membrane is the third eyelid of the cow. Also upper and lower eyelid of the eye. Usually lateral corneal scleral junction. You usually see it in the corneal scleral junction. In non-pigmented skin due to sunlight, and it may be heritable. And this is the eye of a cow. This is the third eyelid, and you see the tumor. This is a squamous cell carcinoma. You see a secondary infection. See this purulent discharge. So normally the third eyelid of the cow is it's marginally visible. You have to look at it very carefully, and then before you can notice it, and you can appreciate now how enlarged it is. Well, that's a squamous cell carcinoma. It can also appear in the eye, in the upper eyelid, or in the lower eyelid. And the most common treatment is resect it. You block it with a local anesthetic. You retract it with a like an Ellis tissue forceps, and then you simply cut it with a scalpel blade or scissors. There's also some radiotherapy and cryosurgery that can be used. In severe cases, the animal needs to be slaughtered. Be reminded that if there are animals that get slaughtered like this, their meat could not be sold for human consumption. If they suspect that there is a metastatic involvement to the regional lymph nodes of the head. Infectious bovine keratoconjunctivitis, IBK. Infectious bovine keratoconjunctivitis is also called pink eye in cattle. The agent, Moraxella bovis. Usually one eye. There's corneal edema with ulceration, usually a central opacity or central ulceration, and one of the first signs that we see is epiphora, or with a watery secretions, lacrimation, profuse lacrimation, with blepharospasms and photophobia. So watery, profuse lacrimation with blepharospasms and photophobia are one of the early signs. Then we have a corneal edema. Then we have ulceration. In severe cases, we have marked vascularization of the cornea with a possible eye rupture. You can have an iris bombay, anterior synechia. All of these ophthalmological problems can occur in this condition. Treatment. The early signs we can treat with a local antibiotic. We can also treat with a systemic antibiotic such as oxytetracycline. If we have a group of calves, this is usually a condition in young animals, 3 to 6 months of age, and you have in a group of 10 calves, 1 or 2 begins with the signs of pink eye. What you want to do is you want to treat the affected calf with a local antibiotic right into the so it's a subconjunctival treatment. But then you want to treat the pen mates or the herd mates. You want to treat them with an antibiotic treatment such as oxytetracycline to treat the carrier state, because a lot of the other animals may be carriers, and to prevent the infection from one calf to the other. So we can use, in terms of the treatment, we can use local antibiotics or systemic antibiotics. The systemic is most commonly oxytetracycline. The local is a penicillin. Or we can do a third eyelid flap. Take the nictitating membrane and simply bring it across and have a temporary stitch to block sunlight. Or you can put an eye patch also in some of these eyes. And this is to prevent further damage from sunlight. This Moraxella bovis is ubiquitous in the environment, and the reason why young animals get pink eye is related to too much dust, too much sunlight, so we have to provide some shade to these animals. We have to try to cut down so that there isn't a lot of dust. And any damage to the descent membrane of the eye can predispose these animals to pink eye. So certainly IBR, BBD, any type of viral infection that can affect the eye will predispose, or the cornea will predispose these animals to eye decay. And this is kind of what it looks like. You want you to appreciate the cornea, the central corneal opacity. Central corneal opacity. And there may be some neovascularization in the on the periphery here in the corneal scleral junction. You may begin to see some vascularization because that's how it heals. The third eyelid is not involved. Udder health and mastitis. Very briefly remember that there are mastitis control programs. We want to have proper milking management, which means that after a cow gets milked, we want to dip each teat after milking with an iodine-based dip. Okay, that's number one here. That's the most important one. After milking procedures, we want to dip the cow with an iodine dip and make sure that the cow is properly stimulated before milking, and that we examine the secretions to determine whether or not she has mastitis. Environmental control, we want the cows in a clean environment as possible. Okay, that the cows, we want to milk a clean cow, not a wet, dirty cow. So this involves the control of the environment. Number 3 is dry cow therapy. After a cow ceases milk production, as I mentioned earlier, we give her a 2-month dry period or rest, and at that time we want to use an intramammary antibiotic treatment to control the infection. Number 4, milking machine maintenance. Proper milking equipment with a proper vacuum, the proper rest to milk ratio, and then appropriate treatment protocol. So these are the 5 basic programs or basic points, if you will, that we have to try to control mastitis and prevent mastitis in most dairy farms. Mastitis causing agents. We divide them into 2 groups. Primary udder pathogens or contagious organisms, that's Staph aureus, Strep agalactiae, Mycoplasma bovis, and Streptococcus galactiae. And then with the environmental pathogens, we have Strep uberis and also Strep galactiae. Remember that Strep agalactiae is a CAMP positive, CAMP positive bacteria. want to bring to your attention some diseases affecting the urinary system. I've just listed them that I think you should be aware of. Urolithiasis. Remember that in bulls is in the urolith is in the sigmoid flexure. In sheep or in rams is at the urethral process. Pyelonephritis, postparturian hemoglobinuria, which is a hypophosphatemia, and then bacillary hemoglobinuria, which is a Clostridial hemolyticum infection. I think that you should review these conditions. In the digits or problems with feet, foot rot or interdigital phlegmon, laminitis, subsolar abscesses, interdigital fibroma, and digital dermatitis. These are the 5 most common problems with feet or with the digits of dairy cows. Nervous disorders, listeriosis, which is a differential to TEM, tetanus, Clostridium tetani, as a result to metritis or to related from a calving trauma, rabies, pseudorabies or Oshinsky's disease, botulism, bovine spongiform encephalopathy, and perhaps even anthrax would be some disorders that are important. Parasites, lice, ticks, osteotagia, dermatophilus, warts, ringworm, and mange are conditions, disorders that you need to review. And finally, I just want to conclude with the most common antibiotics that we use. Penicillin, the dose is 20,000 to 60,000 units per kilogram IM every 6 hours. Sulfadimethoxam is the only sulfa that we can use in food animal, 10 milligrams per kilogram sub-Q. Orally, we can go 50 milligrams per kilogram initially, and then 25 milligrams per kilogram. Oxytetracyclines, 10 milligrams per kilogram IV. Fluorphenicol, 20 milligrams per kilogram every 48 hours. Ceftiofur, 1.2 to 2.2 milligrams per kilogram. The advantage of ceftiofur hydrochloride is that the milk does not have to be discarded. This is an antibiotic that can be used, that it doesn't cross the blood-milk barrier, and the milk does not have to be discarded. And then ampicillin. And penicillin, sulfa, and oxytetracycline, and ceftiofur are antibiotics which are commonly used for respiratory problems. If we're dealing with mastitis, we probably would use penicillin. If we're dealing with metritis, we probably would go with a penicillin or a ceftiofur. So I've given you, these are the most common antibiotics that we use in food animal medicine with their dosages, and of course for the treatment of respiratory problems, renal problems, or urinary tract infections, and metritis. The other thing that I want you to remember, that it's critical in the United States that when a veterinarian prescribes an antibiotic, they must have a valid doctor-client-patient relationship, and that the veterinarian prescribes these antibiotics, they must follow label instructions and use the antibiotics according to what's in the label. That means the disease, and that means the dosage. If you divert from the disease or the dosage, you're not following off-label, you're not following label instructions. And then finally, I'm going to leave you with some common anti-inflammatory drugs that are used. These are, if you're going to use as anti-inflammatory treatment, aspirin works well in cattle, 100 milligrams per kilogram per os every 12 hours. Flunixin, meglumine, 1 to 2 milligrams per kilogram IV or intramuscular. These two are excellent non-steroidal agents that can be used in toxic conditions or as fever reducers. Some non-steroidal, continuing with the anti-inflammatory Well, in this case, these are steroids agent, dexamethasone. For shock, 1 milligram per kilogram IV. Inflammation, if we want to reduce the inflammation, 0.15 milligrams per kilogram IM. And there's isoflupridone acetate for treatment of ketosis. We can go with 0.04 milligram per kilogram IM. This dose here is the inflammation dose here in dexamethasone is good for ketosis. This concludes my lecture. I encourage you to go to the text that I mentioned to you to compensate or to correlate my lectures, my presentation with those textbooks. Also, we will have an opportunity for a question and answer session, and please come prepared to ask the questions that you have regarding my presentation. Thank you very much.